Hello, good afternoon. I'm Manjot Gill, Vice President of the Medical Faculty Council, and we are the body that represents the faculty of the Feinberg School of Medicine here at Northwestern. We serve as the liaison between the Feinberg faculty and the medical school administration, and really are a platform for the faculty to voice their concerns and offer any feedback related to the medical school. The goal of the MFC is to foster a culture of excellence in academics and promote collaboration, communication, and mentorship within the community here at Feinberg. Each year, we sponsor two IPHAM lectures, and these really serve to highlight the cross-collaboration that occurs between multiple disciplines in the School of Medicine and to advance the care of our patients. And today's lecture is no exception. So I'm going to turn it over to my chair, Dr. Daniela Ladner, Professor of Surgery, who will introduce our speaker today.
Thank you, Dr. Gill, and welcome to the IPHAM seminar series. As you all know, IPHAM is hosting this series every Thursday at noon. And as a representative of the Medical Faculty Council and as the co-chair for the combined MFC and IPHAM seminar committee, together with Dr. Gill, I am honored to introduce one of our rising stars in surgery, Dr. M Stey. Dr. Stey is an assistant professor, has been with us since 2019. She obtained a Master in Science at the London International School of Economics and Political Science in International Health Policy, and shortly thereafter got her MD at Mount Sinai in New York. She did her internship and residency in general surgery at Mount Sinai in New York, and in between did a postdoctoral fellowship in health services research at UCLA. After this, she went on to do 3 fellowships, one in pediatric surgical oncology at Memorial Sloan Kettering, one in surgical critical care at UCSF, and then trauma acute care surgery at UCSF before she joined us in 2019. She's published over 30 peer-reviewed manuscripts and was a recent first author for the publication Emergency Department Length of Stay and Mortality in Critically Injured Patients in the Journal of Intensive Care Medicine. She's been invited to lecture as a lecturer nationally and internationally, and is a reviewer in many journals such as Annals of Surgery. She's already received mentorship and teaching awards and is a member of many societies, including the Central Surgical Association. She's most recently received the K23 Career Development Award from NHLBI for timeliness of management of trauma-related hemorrhage and trauma-related coagulopathy. This is a very coveted career award. So in brief, Dr. Stey is a trauma surgeon and surgical intensivist who is passionate about addressing inefficiencies to improve healthcare quality and cost of all patients. Her ongoing research focuses on improving quality and value of care with an underlying goal of helping the US healthcare systems become more efficient and equitable for all critically ill and injured Americans. Along those lines, she will talk to us today about improving trauma systems of care. If you have any questions during or after Dr. Stey's presentation, please use the Q&A button at the bottom, and we will answer all your questions at the end of her talk. It's a pleasure to have you today, Dr. Stey.
Thank you so much. So today, as Daniela mentioned, we'll be discussing improving trauma systems of care. So a question to the audience to get everybody thinking. What is the most common cause of death for Americans from 1 to 44 years old? I'm going to put some hints up on the screen. And then what is the most common cause of disability worldwide? So unintentional and intentional injury are the leading cause of death in the United States. These are data from the CDC from 2018. And as you can see, unintentional injury is the most common cause of death for individuals from 1 year of age to 44, followed by intentional injuries such as suicide, homicide, trailing as 2, 3, and 4. And this is true especially in the COVID era. So traumatic injury is still a leading cause of death. And as you can see, it's the 4th leading cause of death in 2020. Trauma systems historically have improved during periods of war. The war has led really to the major developments in trauma systems of care. In 1861 to 65, the Civil War prompted developments in triage and aid stations and transports to hospitals. President Lincoln actually drove creation of the first trauma manual, which was the first documentation of injury and the care of injured patients. 1939 to 1945, World War II researchers actually went into the battlefield to understand how injured patients were taken care of. And shortly after World War II, in 1946, the Hill-Burton Act funded states to build emergency departments. In 1966, the National Academy of Science relayed a report to President Lyndon B. Johnson, which was the accidental death and disability, the neglected disease of modern society. And they noted in this report that injuries are the leading cause of death in the first half of an individual's lifespan, which is still the case today. And more Americans are killed in US traffic accidents than were killed in the Korean War. They also noted that Americans in combat had a better chance of surviving than if they were injured on American roadways. And so this really spurred quite a bit of innovation in trauma systems, and really trauma systems groundwork was implemented largely starting in 1966. That's really where we developed pre-hospital care such that emergency medical technicians and paramedics became trained and recognized as professions. We also developed the 911 system. Additionally, there were policies such as the Highway Safety Act, which required all states to develop emergency medical services systems. We also had improved data collection. So the National Trauma Data Bank actually was launched at this period, and the American College of Surgeons established data definitions for the National Trauma Data Bank. And it was one of the first repositories. We also had a specialization of hospitals, where Cook County actually was the first hospital to specialize in the care of the injured patient with their trauma unit that is still running and an important part of our trauma care here in Chicago. So we had a rapid proliferation of support for trauma systems in the 1960s and 70s. The 1973 Emergency Medicine Services Systems Act financially supported regional EMS systems. In 1976, there was a publication, The Optimal Resources for the Injured Patient, and this is where the American College of Surgeons actually outlined criteria for trauma center designation and verification. And then in 1980, the American College of Surgeons began the Verification Review Committee. And this actually serves as the first model for regionalization of care, where hospitals started to be recognized as trauma centers, and later inspired many such innovations in regionalization of care, both in adult and pediatric care, oncology, and many different forms of medical care. And upon doing that, they noticed actually that there was a relative reduction in the relative risk of in-hospital mortality and mortality at 1 year among injured patients. And this was a study published in 2006 that looked at these data and demonstrated that there was a benefit, especially among the most injured patients. This led to what was defined as the CDC field triage criteria, also in 2006, which again sought to try and get patients to those high-level trauma centers where they would see a mortality benefit by identifying patients who met specific conditions out in the field to prompt EMS and paramedics to take them to trauma centers. This was later refined in 2011 to make it more streamlined and straightforward for paramedics and EMTs. So in 1990s and 2000s, there were a couple of stepping blocks. And although there had been some legislation in 1990 for trauma care system planning and development that financially supported the development of trauma systems nationwide, it was eliminated from the federal budget in 1995. And then in 2001, HRSA created the Trauma and EMS Systems Program, but that was later eliminated from the federal budget in 2006. And so to this day, there's still no federal funding for trauma systems or trauma care. It's all done at the state level. And so one of the first questions that we wanted to understand were, how does state trauma funding impact in-hospital mortality? This was a retrospective observational cohort study, and we collected trauma funding data from state's Department of Health. We linked these data to the 2010 to 2011 National Inpatient Sample and the 2010 American Hospital Association survey. And we compared the adjusted in-hospital mortality rates of injured patients in states with trauma funding. We found that few states have data, and even fewer have trauma funding. There are around 500,000 injured patients that we identified across 17 states with publicly accessible trauma funding data. And trauma funding per capita ranged from $0 to $8, with a median of less than $1, 0.93 per capita. The interquartile range was 0.91 to $2.10 per capita. And we were able to divide patients in states into funding quartiles, where there were 7 states with $0 per capita, 3 states with less than $1, and 3 states with between $1 to $2.9, and 4 states with greater than $3 per capita of trauma funding. We found that increased trauma funding was associated with decreased adjusted in-hospital mortality. And so we used the less than $1 group as a reference, and we saw that both patients that were taken care of in states that had between $1 to $2.9 per capita of funding, as well as patients who were taken care of in states that had greater than $3 of funding, had a reduction in the adjusted odds of in-hospital mortality. And there's almost a dose dependency that you can note here, where greater than $3 actually saw a greater reduction. And we also saw that, as the New England Journal paper from 2006 demonstrated, that patients who were cared for in non-trauma centers had a higher odds of in-hospital mortality. And so we postulated that some of this might be because more patients were being taken care of at non-trauma centers or taken directly to high-level trauma centers when they were injured. So we wanted to understand, how are trauma systems getting the right person to the right place at the first time from the field? We did a retrospective observational cohort study where we linked 2020 IDPH Region 11 crash data to the Chicago Department of Public Health EM hospital resource data. We used geocoding and calculated the distance between the crash site and the hospital where EMS transported the patient. And we noted that the average speeds on the shortest path roadways and used that to estimate the transport time. We found that most injured patients are taken to the closest non-trauma hospital. And you can see around nearly 200,000 patients were taken to the closest non-trauma hospital. And then only a fraction of those patients, about 20% or so, were taken directly to trauma centers instead of a non-trauma hospital. And then you can see patients were taken in many different places, not just the closest couple of hospitals. When we then looked at patients who had an incapacitated injury or were noted to be incapacitated in the data, we saw that most were also still taken to the closest non-trauma hospital. And so there were nearly 2,000 of these patients who were taken to the closest non-trauma hospital. And a larger proportion of them were taken to a trauma center. However, ideally, these are the most severely and critically injured patients who ideally should be managed at a trauma center, a high-level trauma center in particular. So we wanted to understand, could part of the reason that this is happening is because hospitals were on bypass. This was 2020, hospitals were very busy. So because hospitals weren't allowed to say that they were on bypass in 2020, we defined bypass as having 0 ICU beds and 0 ED beds. And we found that actually 13.7% of patients were not taken to the closest hospital because the closest hospital was on bypass, and that around 19.6% of incapacitated patients were not taken to the closest trauma center because that closest trauma center was on bypass. But still, 10.6% of patients were not taken to the closest open appropriate facility. But the transport time difference, we're talking about region 11, which is Chicago, was actually less than 5 minutes. And so even though they weren't taken to the closest facility by rank, that doesn't necessarily mean it probably led to major delays in their care, since the transport time was less than 5 minutes. However, we did note that around 39.1% of incapacitated patients were taken to non-trauma hospitals. And so that's considered under triage, when patients who are severely or critically injured, who according to CDC field triage criteria should be taken to a high-level trauma center, are not. And around 3.6% of patients were over triage. So these are patients who were taken to trauma centers who maybe didn't necessarily need to go to a trauma center. So how can we ensure that the right patient gets to the right place at the right time, not just the first time? And so to delve into under triage a little bit more, it's the misdirection of a severely injured patient to a non-trauma or a low-level trauma center that's not able to take care of their injuries. And it's estimated that between 17 to 34% of patients are under triaged. And so our estimate of 39% is close to that, the upper limit that's been reported in the literature. We know that under triage patients experience increased mortality, the same way that patients who are appropriately taken to trauma centers have lower mortality. There's a 30% increased mortality at 48 hours for the patients who are severely injured and are taken to non-trauma or low-level trauma centers. And retriage is actually the emergent transfer or routing of severely injured patients upon arrival to a non-trauma or low-level trauma center to a high-level trauma center. And so when we start thinking about how we can get the patient to the right place at the right time, retriage is a potential important tool to make sure that patients get the care they need in a timely fashion. And there has been some literature that's demonstrated that rapid retriage of critically injured patients actually leads to similar outcomes as patients who are taken directly to high-level trauma centers. And so this study in particular looked at standardized processes that try to rapidly transfer patients from non-trauma centers to higher level of care centers. And they found that they had a median time of around 130 minutes at these non-trauma centers. And when they broke it down by the patients who survived and the patients who did not survive, the median time in the patients who did survive was around 125 minutes, whereas the patients who did not survive, the median time in the non-trauma centers was 195 minutes. And so timeliness is very important, in addition to making sure that these patients just get transferred to higher level of care. So there has certainly been some data that suggests that in general, the average retriage time is closer to 4 hours. And that's been internationally, not just the US system, which is arguably one of the most mature trauma systems in the world. And that between 30 to 50% of patients are never retriaged. And so we wanted to understand our trauma systems patients, specifically within the NM system, getting to the right place at the right time. This was, again, a retrospective observational cohort study, and we used 2015 to 2020 Northwestern medicine system-wide data to identify critically injured patients who presented to the emergency room with an initial systolic blood pressure less than 90 millimeters of mercury. We used random forest multivariate survival analysis, and we quantified the time to stabilization. So the time to a subsequent blood pressure that was greater than 90 millimeters of mercury in this group of patients who presented initially with a systolic blood pressure less than 90 millimeters of mercury. And we've then looked at retriage rates among patients who were successfully stabilized. And really what we were hypothesizing is potentially one of the delays to getting patients retriaged in a timely fashion is the fact that they're not stable to put on an ambulance. So really the Northwestern medicine system is a fantastic system to study this in, because we have 4 non-trauma centers and we have 5 level 2 trauma centers, as well as our 1 level 1 trauma centers. And they're in very geographically distinct places in different regions across the entire state of Illinois, from very urban areas such as our hospital here downtown, and some more rural hospitals, as well as some critical access hospitals. So we found a total of 1,367 Northwestern medicine patients who presented with an injury that had a systolic blood pressure of less than 90 millimeters of mercury. And they were actually presenting to all 3 levels of trauma centers. So again, suggesting that there is a fair amount of under triage even within our system across all these different regions. 23% of these patients presented to non-trauma centers, 62% presented to level 2 trauma centers, and 12.3% presented to our level 1 trauma center. The median time to stabilization was actually 50 minutes. So certainly within what we talk about the golden hour of an injured patient, with an interquartile range of between 21 to 101 minutes. What was interesting is that successfully stabilized patients were less frequent in the non-trauma centers. And so overall, 43.9% of patients were never stabilized, and we were never able to get a recorded blood pressure in the electronic medical record above 90 millimeters of mercury in the first 4 hours of their presentation in the emergency room. And the rates of patient stabilization really varied depending on what type of hospital the patient presented to. They were 30% at the non-trauma centers, 58% at the level 2s, and 95% at the level 1. We found that critically injured patients are rarely retriaged. So even after successful stabilization, very few are retriaged, only 17.5% of unstable patients at non-trauma centers, and only 4.9% of unstable patients at level 2 trauma centers. And even fewer patients were retriaged if they were never stabilized. So 9.6% of unstable patients at non-trauma centers, and 1.9% of unstable patients at level 2 trauma centers. And so it may be that some patients are just never stable enough for transfer. There are some places, however, where there really is no other choice. They don't have blood banks, they don't have surgeons, so they really do need to just get the patient on the rig or they'll die in the hospital. So we found that trauma systems are not getting patients to the right place at the right time currently, that most patients are successfully stabilized within those first 101 minutes. But that there are extremely low rates of retriage even after stabilization. And these are lower than the rates that are reported in the literature, which are between 30 to 50% of failure to retriage. So we wanted to understand how frequently does a non-trauma center retriage to the closest high-level trauma center facility. You can think about it as if there's a single non-trauma or low-level trauma center, they have potentially multiple options of high-level trauma centers that they could transfer to. And so we wanted to understand if there were specific practice patterns in terms of where patients were sent depending on the center. So we conducted a retrospective observational cohort study of data from 2007 to 2018 using the California Office of Statewide Health and Planning data from both the ED and inpatient files. We identified patients who presented with an injury severity score greater than 15, and we used GIS network analysis to quantify how frequently non-trauma centers retriage patients to the closest high-level trauma center. We found that the frequency of retriage to the closest trauma center really varied by the non-trauma center itself, that only around 15% of non-trauma centers retriage greater than 90% of their severely injured patients to the closest trauma center. And 70.9% of non-trauma centers actually retriaged less than 20% of their critically injured patients to the closest trauma center. So a pretty big gap in what we'd like to see. We also found that non-trauma centers do not retriage to the closest trauma center when there are multiple trauma centers that they could refer to. We found that the highest density of non-trauma centers was in LA, where they retriaged none of their patients to the closest high-level trauma center. In this map, the blue dots are non-trauma centers that retriaged none of their patients to the closest high-level trauma center. The warm colors are the hospitals or the non-trauma centers that retriaged greater than 2/3 of their patients to the closest high-level trauma centers. So really not a very stable network and not the most optimal pattern of retriage either. So really to understand why aren't severely injured patients retriaged, we have to recognize that most studies that have been conducted in this area have been limited to secondary data analyses, and they lack information about the actual processes of care, and they also lack provider and patient perspectives about why these things happen. And so when we thought about how to study this, specifically why aren't severely injured patients retriaged, we really wanted to be able to talk to the providers who are making these decisions and having to actually go through this process. And so we conducted a cross-sectional cohort study. We conducted failure modes effects analysis, and our goal was to create a process map of the retriage process. Again, we leveraged the Northwestern medicine system. We spoke to individuals in 4 non-trauma centers in the Northwestern medicine system and 5 in the low-level trauma centers in the Northwestern medicine system. And we sought to identify failures in the process map that led to failures in timely retriage. And so this is the process map we came up with. It's very long. Again, it's from 4 Illinois non-trauma centers and 5 Illinois low-level trauma centers. And it's a 26-step process consisting of the trauma evaluation as the first phase, the decision to retriage, which is the second phase, and the third phase, which is the actual retriage process. And what we found was actually when we ranked all the failures was that the majority of the highest risk failures for delaying retriage occur at the receiving or the high-level trauma centers. And specifically, the highest ranked failure was the refusal to accept a patient by the high-level trauma centers, followed by things like delays in calling back folks at the sending hospitals, as well as just bed availability limitations. When we looked at the highest ranked failures at the sending centers, we found that it was really establishing an indication for retriage that tended to be the most common failure. And so specifically enlisting consultants and radiology studies to try and make that determination. And often what the nurses and physicians cited at these hospitals was because they needed that as justification to the high-level trauma centers as to why these patients needed to be transferred. So they didn't feel like they could just call them and say, we have a critically injured patient who needs your services. So we found that failures in the retriage process within the Northwestern medicine trauma system, there's really the highest risk of retriage delays occur from the receiving high-level trauma center. So fortunately, the stars aligned and we were able to start thinking about generalizability. The IPHAM Trauma Advisory Council has led an initiative to uniformly adopt retriage transfer indications. And these are hemodynamic instability as measured by blood pressure, active bleeding, respiratory compromise, neurologic deficits, or orthopedic, plastics, or burn deficits. And the goal, again, is to improve the rate of retriage, but also the timeliness of it. And Illinois adopts the less than 120-minute policy. And again, this has been found in some studies that to actually have equivalent mortality rates to patients who are taken directly to high-level trauma centers. And so arguably it mitigates the risk of death that a patient could suffer when they're taken to a non-trauma center to begin with. So to understand retriage processes and care across the entire state, we conducted a cross-sectional cohort survey study. We surveyed all Illinois hospitals about their retriage processes of care. And we did this in collaboration with the IDPH State Trauma CQI Committee. And we surveyed, again, all hospitals in Illinois to assess the most frequent retriage practices and identify opportunities for improvement. We actually got most responses from non-trauma centers that were labeled themselves as interested in taking care of trauma patients, and actually a fairly good response rate with a total of 76 hospitals responding across all 11 regions of the state of Illinois. And we noted that in particular, there was probably the best response rates from some of the larger regions, Region 2, for example. So the survey reported that all hospitals had at least one trauma center, high-level trauma center, either level 1 or potentially some level 2s, to retriage within 120 minutes of their facility. And so that was reassuring that it wasn't necessarily a rurality problem that limited access to retriage. We found that 21% of hospitals perceive retriage delays, with specifically Region 9 that cited very frequent delays in the retriage process. And there was an average of 1.4 calls per retriage to find an accepting receiving high-level trauma center. And you can see that the regions where this happened most commonly, or where they had to make the most calls per report, was Region 7, as well as Region 9. And when we asked why a non-trauma or a low-level trauma center would retriage to one center over another, they listed two of the most frequent reasons, one being that they were the closest facility. They preferred sending patients to the closest high-level trauma center. And the other was that there was a standardized process for the actual retriage process. Nonetheless, only 41.5% of hospitals said that they had no standardized retriage process. And so again, there's a big gap in hospitals saying what they want to see and what they're actually experiencing. And the three most common reasons for retriage delays that were reported were that the accepting facility was either somehow delayed the transfer because of they weren't able to provide immediate acceptance, or that multiple centers, again, had to be contacted before receiving acceptance. And then lastly, that there were interfacility transportation challenges. And that is not surprising in a state as diverse and large as Illinois. So really our next steps now are thinking about how to design an intervention that really addresses both sides of the coin to improve timely recognition of need to retriage and stabilization in non-trauma and low-level trauma centers, and also to standardize and streamline the retriage process for severely and critically injured patients at high-level trauma centers. And so that's where we're at now currently as part of the K23. And thank you all so much for taking some time and out of your day and listening to this talk. And I just want to acknowledge all the people who've assisted me and inspired me in this path, and be happy to take some questions.
Thank you very much, Anne. This was a fantastic whirlwind through the work you've been doing. And you mentioned a little bit what your next step is going to be. I'm interested to hear, where do you like this to be in 5 to 10 years? What do you think is likely, or in your ideal world is likely to happen? And where do you see barriers towards that you can encounter in this effort?
Yeah, thank you. I think it's quite challenging because, as you can tell, this area really spans everything from policy and economics to actual patient care at the individual, both in the field and in individual hospitals. So I really do think that there's a lot of potential in terms of being able to streamline our processes, both at non-trauma centers and at the receiving high-level trauma centers. So part of it is recognizing who needs to be transferred or retriaged, and doing that in a very systematic and standardized fashion with shared language between the non-trauma centers and the high-level trauma centers, so that the non-trauma centers or the low-level trauma centers don't feel like they need to do a $3 million workup before putting a patient on a rig if they need higher level of care. So that's one piece. I think the other piece is really being able to flesh out who is the referring receiving hospital, who will accept patients. And so California has done quite a bit, has really been a leader in this area. And they have established in certain LEMSAs or EMS regions, they've established a buddy system where certain non-trauma centers and low-level trauma centers will always refer to one high-level trauma center. And that trauma center pretty much always has to accept these patients. And again, the goal is to just create these very standardized, streamlined processes where this always happens. There's no question, there's no pushback, there's no delays in answering the phone or trying to get a consultant to accept the patient or to evaluate the patient or to take a look at the CT scan or to decide whether it's something that is worth transferring your higher level of care, with the understanding that some patients may be over triaged and may end up at a high level trauma center who maybe don't need it, but that will probably still be safer for patients and lead to lower mortalities, even though it might increase costs a little bit, than what we're doing right now, which is that still a lot of critically injured patients are going to and staying at non-trauma centers across the country. And this is really not just an Illinois problem. It happens really all over the country. And there's also a real lack of ambiguity about who should be retriaged.
Thank you. I have a few questions here in the question and answer session. One from Alexander Elin. Thank you for this very informative presentation, Dr. Stey. I was wondering if there have been studies done yet that assess retriage times and rates pre-COVID versus post-COVID, since there may be more high-level trauma centers not able to accept severely injured patients during the pandemic.
Yeah, that's a great question. No, there haven't. Part of it is that we have relatively sparse pre-hospital data, although NEMSIS now has been very successful in building a national repository of EMS field data. We still struggle. We struggle to be able to have robust pre-hospital data about where patients presented, where they were taken, and then being able to actually link that to outcomes. And so it's really an exciting and challenging space to investigate.
Thank you. Jiafeng Zhu is writing the following. Hi, Dr. Stey. As I know, there are multiple ways of transportation, ambulance, helicopter, and so forth. Does the trauma data you used have this information? And it might be helpful to take it into consideration when adjusted for the distance between event location and site. Right.
Yeah, no, absolutely. So in our California study we estimated that hospital that you would have a fixed wing transport if you were greater than 50 miles then between two hospitals. And if it was less than 50 miles, we assumed that it was probably ambulance transfers. So our trauma registry does not capture those data. None of the administrative data that are available nationally and at the state level capture whether patients were transported by fixed wing or air. And even finding administrative data where you can even link patients to see who went where is actually extremely difficult. There's a lot of missing data. There's a lot of variability. Also, you often need to use multiple variables to be able to link patients across. So unfortunately, there's definitely an absence of good data. We make assumptions based on the distance traveled and the rurality of certain districts, but there's definitely a big gap in the actual data that's available.
Thank you. Jeffrey Linder is asking, as he says, a super specific question. In your analysis of patients with a blood pressure less than 90 millimeter mercury, how did you operationalize that they had a trauma?
The patients who've had a trauma can be identified using E-codes or their ICD-9 or 10 codes that code for the mechanism of injury. And they are, depending on the state, they're compulsory to submit and should be reported for every single patient. That is variable. It probably, we undercapture patients who had a traumatic mechanism, but theoretically, that is something that is supposed to be coded and reported at the hospital level.
Then Eleanor Kaufman says, great talk, an amazing level of detail. At my level 1 center, we cannot refuse any transfer unless bed conditions are the most extreme or unless it's unsafe. This is partially motivated by finances. out of system transfers are a plus for us. Do you think this is a potential downside of system concentration in your system?
Yeah, I think that's an amazing question, Eleanor. And you know, it really gets at this idea that there are potentially also perverse incentives, right? So most states, they really pay the receiving hospital, the second hospital that admits the patient. So if you are just, you see the patient in the emergency room and you transfer them out, your hospital will not get a substantial portion of reimbursement for the care that was provided. And so that there have been many studies that have demonstrated that patients who are privately insured are less likely to get retriaged, as opposed to patients who are underinsured, uninsured, or publicly insured. And so as these big hospital systems proliferate, you know, they're leaving money on the table when they transfer these patients out. I think it's a fantastic question. And I think the opportunity, however, with it, when you have in-system transfer of care, is that you have a shared medical record. You are able to see everything that was done for the patient. You're able to see their CT scans. There's really very little redundancy in terms of testing or medications that needs to be done, because you can really see everything that's happened. And there have been some data, especially in some states in Colorado, that suggests that they're able to get a patient basically in the operating room in 20 minutes. You know, if they get them on the helicopter, transfer the patient, they know that they need their spleen out, or that they need they have a blunt aortic injury and they need it to be repaired. And so that offers a lot of potential benefit. I'm not sure if that, you know, I think it still needs to be determined whether that the increase in distance, whether that makes any difference. Because again, it's really more about time as opposed to distance. So if you're able to limit the redundant testing that happens in the emergency room, or if you have these auto accept policies, that may cut down the time enough that you're actually able to provide them just as timely care as perhaps a closer center.
Another question from an unnamed attendee. What is the role of patients and other community stakeholders in driving these questions and in acting on the learnings?
Yeah, that's a really great point too, because we know that a common reason why patients will be under triage or won't get transferred to higher level of care is because they want to stay in their communities. They want to stay close to family members, and you know, the possibility that they may not be able to have their support system close by, or that their family members will have to travel many hours to go and see them, can really dissuade them from getting their hip fixed to a higher level center of care, where, you know, there's more orthopedic surgeons who are able to do all that all day, every day. So I think that patients and families have an extremely important voice that needs to be heard around this. And also, we should do a better job about explaining the benefits of regionalization of trauma care.
And another attendee that is unnamed said, as an ER nurse here at NMH, there are trauma criteria we follow. Do lower level and non-trauma centers have criteria to follow for guiding transport to appropriate level of care? Is there a training opportunity for some type of retriage once taking the radio call, which would assist getting the patient to the right place?
Yeah, that's such a great point, and it's such a great, that really is, I think, where we need to go. The fact that IDPH finally, a year and a half ago, published these criteria of who should be retriaged emergently, I think that at least allows us to build shared language across the state of Illinois about who we're going to retriage. And the reality is it's extremely different across different states. And some states don't even have formal policies. We didn't until 2019. So absolutely, I think that there is definitely an opportunity to educate as to what our criteria, and also to define what our criteria better, because as you may have seen in the slides, how IDPH defines a retriage, or indication for retriage, is hemodynamic instability. What does that really mean? Is that a systolic blood pressure of 60? Is that a systolic blood pressure of 80? Is that a systolic blood pressure of 90? Which, in somebody who usually lives at a systolic blood pressure of 160, that's very hypotensive, right? And so really being able to also come up with numbers that, at least across our NM system, but ideally across regions in the state of Illinois, though I know that was contentious when these criteria were being passed. I think that it's a huge opportunity for us to really be able to create more shared language across all these different hospitals, because that's what makes it hard, right? Is you're coordinating care across very different hospitals and very different individuals.
Dr. Nandita Nadig is asking, thanks so much for sharing your experience and expertise. I was curious about the process map you mentioned as it relates to trauma retriage. I wonder if these maps would look different based on the type of initiating hospital / community, or if it's rural versus urban. Maybe some steps could be generalizable and others adaptable to specific local setting.
Absolutely. And what we have seen, what we saw when we looked at the California data, and what Avery Nathans and his group have seen in the Canadian data, is that, again, what we mentioned around Los Angeles is that you have a very high density of high-level trauma centers. You actually struggle more with getting your patients to the right place at the right time. And so, exactly why that is, it's a little bit difficult to say. Perhaps it's that there's more refusals on the part of the high-level trauma centers because they say there's always another place that you can transfer to, or perhaps it's that urban centers are maybe already just too overwhelmed and don't have beds to accept patients. It's difficult to know, but what we have seen certainly in secondary data analyses is that the rural areas do a better job of getting patients to the closest hospital consistently and more frequently.
Another comment, thank you so much for this presentation, Dr. Stey. I was wondering what other reasons, beside the lack of available beds, would a level 1 trauma center have to not accept critically ill patients?
Well, I don't think that, it's difficult. We mostly spoke with non-trauma and low-level trauma centers to understand their experience. I think the reality is, the high-level trauma centers usually have to take not just traumas, they have to take higher level of care for stroke and pediatric and transplant and oncology and, complex cases that are being referred to them from other outlying hospitals. And so I think a lot of it really comes down to institutional and system-wide priorities, and what they feel that they can absorb and what they feel like they can't absorb. There's been there have been some studies, but most of them are secondary data analyses showing that insurance rates and things like that can potentially incentivize people to accept or not accept patients. But we're really just postulating at this point.
Well, thank you, Anne. There are no more questions from the attendees. I have one more question. You mentioned cost earlier in answering one of the questions, and that maybe actually this would increase cost, but would lead to better outcome. I wonder if you or other teams are involved in cost effectiveness analyses that would incorporate or account for loss of life, because that obviously has a societal cost also.
Absolutely. No, I completely agree. I think it's extremely important, and that really has to be part of the equation. We have these defined thresholds of 25% as an acceptable over triage rate, and actually quantifying what that means and if that's the right number in terms of both quality and lost years of life, I think is extremely important. And so that's why both quality of life measurement and patient-centered outcomes, I think, really need to be an important part of what we do moving forward, because both death and disability happen at very high rates for these patients. And if we can quantify that better, I think that we can really understand why we need to be doing this and why this really needs to be a priority when our systems are already, very much strained and struggling to keep up with all the patients that we need to be taking care of.
Well, thank you again, Anne. This was wonderful, and I'm so glad we had time to answer a lot of questions from the audience. For all of you, please join us next week for the public health webinar, Medicaid Expansion and Emergency Department Wait Times with Lindsay Allen. And the registration link is placed into the chat. Have a wonderful afternoon, everybody.
Thank you, Anne. That was wonderful.
Thank you. Thank you all.